we are designed to walk, we are designed to run. If you look carefully at your body, the strongest muscles are below the belly button, and they are the most unused muscles when you are a chair worker. It actually deconditions your lower half of the body.
What was that one weirdest case that you remember?
This was a case of a lady. She was around 60 years. She couldn't walk, and she was just 23 kgs.
23 kgs,
Yes.
a 60-year-old woman.
My anesthetist told that the doses of anesthesia will be such that you have to finish the surgery within 25 minutes. When you operate such patients, you are not just focusing on the surgery. What will happen if this goes wrong? What will happen to the family? What will happen to their finances? So that raises one question. Should we be working without getting connected to the patient?
Hello everyone, my name is Shashank Gupta. Welcome to our very special Doctor's Day podcast, The Joint Operation. The goal shouldn't always be to replace the knee. The goal should be to save it. Said who? Our very special guest for today. He comes with an experience of over 30 years, having performed over 15,000 successful surgeries. That includes over 6,000 hip replacement surgeries, over 6,000 knee replacement surgeries, and something that we are going to talk about in detail today, something we call MRP, the Meniscus Replacement Procedure. That's right, he's performed over 2,000 successful MRPs as well. Please join me in welcoming Dr. Ashwani Maichand.
Thank you, Shashank. Thank you very much.
So, sir, let's start. Tell us something about yourself. What was it exactly that inspired you to become a doctor in the first place?
It's your parents, basically. And I would actually give credit to my Dadaji, my grandfather.
Oh,
I would like to take his name here.
yes, please. We would love to have
my
his name.
respect to my late grandfather, Shri Badlu Ramji, who never went to school himself. But he wanted someone to be a doctor in his family, and now we have 5 doctors in my family.
So once you became a doctor, what was that defining moment in your career that actually changed the shape of how you practice today?
Actually, when I started my orthopedic practice, initially it was like it's a great branch and you can earn well. You have very small vision. Your thinking is only limited to that part. But once you start taking care of patients, then you suddenly realize that after seeing certain patients that our surgeries are not simple surgeries. They are defining moments in someone's life journey. It can change the person not only physically, professionally, and financially. Most of them are like patients who are between 20 to 50 years of age. They are the people who are the earning members of the family. The whole future of the family changes depending on the result of my surgery. Then I realized that how responsible the job is. Why not change things? How we think about surgeries? How can we change it? So then you start challenging the conventional. Means things are being done in this way for last 30 years, 40 years. Can I contribute something to it? So these are the things that stimulate you to think beyond the box, means out of the box, what you call conventionally.
Yeah.
So means it happened about 20 years back.
Okay.
When I started practicing independently, and I could see that my small decisions can make differences. So why not to change those decisions? Why not to change the thinking process?
Interesting, because what I feel is a lot of times even the patient themselves are not able to think along these lines. I mean, it's not just a surgery, it's not just a procedure, it's a life-changing event in itself. So I think that's an incredible way of looking at things. So 30 years, more than 30 years into this profession.
Yes.
And you're still going strong, and day in and day out, you come in and you try and change lives and make people's lives better. What is the motivation behind all of this? What keeps you going?
The smile at the end of the day, at the end of the treatment, the family who came desperate and hopeless, and suddenly after a few months when they come for a review, the whole family is changed. Not only the way they look, the way they wear clothes, the way they walk with the confidence in my room, sometimes with flowers or small gifts from their towns. There's no price for it. You cannot evaluate it in any material terms. Those rich emotions, those things that you get every day without asking for it. It's just a job, but that's why I call it the most beautiful profession.
Yeah, and it's such a beautiful picture that you painted.
Respect, blessings. Of course, you earn well if you're doing well.
Yeah.
That's a different thing. And it helps us to be ready for the innovations. Means every few months I'm traveling to people who are doing different jobs throughout the world. I go to them, I share my ideas, I take their ideas, and we create more things. How can we make people better? How can we make them more physically abled? How can we take care of their agony and pain? How can we shorten the that painful journey? Means that keeps on giving you that ignition.
Right.
You keep on flying in that direction. You want more people to be happy. It means, of course, there's a limited time. Your career is limited.
Yeah.
But whatever time I have, I want to give my best to the families and the patients and to the public.
That's such a beautiful picture to even think about or to imagine, like the way you painted the whole thing. And I think, yeah, that would motivate a person. Now we know that you handle a lot of cases. Let's just dive a little deeper into the problems associated with the knees. So, how does that start?
Actually, it is more related to our lifestyle. Now, more and more people are into sedentary work style, like ours. Most of the time, we are sitting.
Right.
And it actually deconditions your lower half of the body. If you look carefully at your body, the strongest muscles are below the belly button, and they are the most unused muscles when you are a chair worker. So what happens? Means we are designed to walk, we are designed to run, we are designed to use our lower body more than our upper body. But our lifestyle has inverted the things. Body weight is transferred through two columns. One is bony column, second is muscular column. We are losing both by being sedentary. So what happens? The biomechanics of the knee are getting adversely affected. They are not getting positively stressed. Stress can be negative or positive. To stimulate bone growth and to keep our muscles toned up, we need positive stress, we need exercise, we need loading, we need walking. But all these things are getting deleted from the syllabus. Because most of the time we are working on a laptop or a system, or we are watching a phone or watching a movie or something.
Right.
Even our jobs, they need 8 to 10 hours of sitting. So that is the real reason. Second, lack of sunlight.
Because most of the times people are inside.
We are indoors.
Right.
Even in your car and means working, is there hardly any exposure to sunlight, which is a very vital part to keep your bones healthy. So these are the two main reasons why younger and younger people are coming to us with knee problems.
I mean, thank you for sharing that, because I think that is not something that a lot of people consider, especially the sunlight part. I mean, we've heard that people have a deficiency of vitamin D maybe, and sometimes they take some supplements to counter that. But the way it affects lower body or our muscular or bone strength, I don't think any of us, or most of us rather, would have thought about it in that way. So thank you for putting it out there. So when it actually starts, what would be the early symptoms? How does one start identifying what are the things to watch out for, rather?
First signs will be that you don't feel like climbing stairs. You have some discomfort. Your body discourages you from using stairs. You rather take a lift, or means you avoid going upstairs. You find other ways of doing it. That is one. Second, after a long drive, when you get out of the car, you feel stiff in your knee. First few steps, you feel that there is something wrong in my knee, and then you take few steps, you feel right. So these are the very early signs. You should realize that there is something going on.
Interesting. And most of the times, people actually ignore these kind of things. They feel that ki aaj main thaka hua hounga, maybe I'm just too tired, or maybe I've just had a long day at work. So people just ignore it most of the times. They don't really think about ki I might have a problem, or this might be a start of something bigger. But when the problem starts getting a little deeper, discomfort increases. I mean, exactly when is the time when one should realize that I should go see a doctor?
We should watch out for red flags. The first thing is that, like, you had some unusually exerting day, like in a weekend, you're going out with friends, and at the end of the day, you feel that there is some bogginess around your knee. It is not exactly swelling, or it's not very painful, but you feel that your knee feels heavy. And when you try to feel the shape, it's not normal shape and it disappears by the next morning. That means your body, your joint is creating extra fluid. Extra fluid means our knee system is giving you extra cushion against some friction that is going on. So collection of fluid is not a disease. It's the body's way of giving you comfort.
Okay.
It's temporary. Many times you forget about it, but that is one. Second, when you are walking and suddenly your knee gets locked, it might happen once a month, once in 6 months. But locking means there is something which is impeding the movement of the bones on each other.
Slight jerkiness.
Slight jerk means suddenly when you change direction, you are not confident. You feel like means I have to stop, take a step, and then you start walking again. These are the signs that there is some biomechanical derangement in your knee, and you should see a doctor.
I think that is very good advice, especially for the younger audiences, because we've seen over a big period of time that people don't actually start consulting a doctor till the things go really bad. But beyond that, do you think there are any other root causes? I mean, we see these problems happening in people who are not really office goers, housewives, or homemakers, or people working in small towns, in other outside work or field work. So what might be some other root causes?
The actual pathology going inside is post 30 years of age, our body starts losing the elasticity. The water content in the soft tissues, whether they are tendons or ligaments or cartilage, the water content starts reducing. Tissues get stiff and slightly brittle.
And this is universal.
This is universal. That is related to your spine or joints or anywhere in the body. A stiff structure is more likely to get damaged, because that pliability factor goes down. And then it needs an excuse to get torn. So if you talk about knee is not just bones. When you look at the X-ray, generally you see two bones,
right?
Femur and tibia.
Yeah.
You don't see other things which are supporting the joint. The other things are, there's a cushion in the center with what we call meniscus, and on the sides, if you look at this cord-like thing, these are ligaments.
Okay.
So these are the things which keep the knee stable and keep the movements smooth. They have high water content. They are very soft structures. They are cartilage and tendons. So once we start losing that water content, the elasticity goes down, then even a slight twisting movement can cause a tear in your meniscus. So your meniscus is the key. This soft cushion-like structure, this actually decides how comfortable or uncomfortable your knee is. So this is the root cause when we start having pain for the first time.
Okay.
Then you need some occasional painkillers. Sometimes you are going for a physiotherapy session. So these are the times you should have the ownership of your health. You should be alert about your health. If these things are happening, go see a doctor.
So like we discussed, you've been practicing this for over 30 years. What was that one weirdest case that you remember? I mean, a case that practically stumped you.
This was a case of a lady. She was around 60 years, having pain in both the hips. She was not able to walk, and her son came with her in his lap.
Okay.
She couldn't walk, and she was just 23 kgs.
23 kgs,
Yes.
a 60-year-old woman.
60-year-old woman. She was just like a kid, and both her hips were to be replaced. Now look at the volume of bone, the amount of blood she was having. Means it was like a borderline case. If you don't operate, she will be bedridden. And how long the life and what quality of life she will be having, we can very well imagine. Average person has around 4.5 liters of blood.
Okay.
She had just 2.5 liters of blood, means that we assess the percentage. So my anesthetist told that the doses of anesthesia will be such that you have to finish the surgery within 25 minutes. Number one. Second, there should not be any blood loss, because 100 ml for a normal person is just okay. 100 ml for her will be disaster.
Yeah. I mean, I can imagine.
Her bones were fragile and she had only one chance. Means every moment when we were operating, all these things were playing on our mind that this lady can walk only once if I do it right. In such cases, we cannot have a retake. And in this case, our MIS technique, the minimal invasive surgery technique, was very handy because it was a short surgery, very small incision, no blood loss, and she was walking within 3 days.
Within 3 days?
Within 3 days.
That is incredible. Just to imagine the kind of pressure one would be in, or the kind of sense of responsibility with a case like that.
Now, this thing raises another question in my mind. I think every professional healthcare worker, every doctor feels about it. When you operate such patients, you are not just focusing on the surgery. There are so many other factors playing on your mind. What will happen if this goes wrong? What will happen to the family? What will happen to their finances, to the future of this patient, and all those things? So that raises one question. Should we be working without getting connected to the patient? How much human angle we should give while we are treating a patient? If we are so much emotionally connected with the patient, that burden you carry inside the OT, which is not an ideal situation. But if I work like a robot, then again it's not right. So how much emotional connection I should have with my patient? That is something that you have to titrate.
Striking that balance.
You have to strike that balance.
I can recall watching Munna Bhai as a kid, and like you said, there are no retakes in life. I mean, we can take as many retakes as we want during the shoot, but in life, when you're there, when you're in the OT, when you have a patient on the table, there's no scope for a retake, and that's incredible. So I'm sure over a period of time, you have somewhere found that balance to not be completely robotic and to not let yourself be completely emotionally attached to the patient.
So I think my OT door is the region where I just get disconnected. Then I am just a surgeon. But beyond that door, I'm a human being, treating a family.
Okay, so over a period of time, we've seen the line of treatment or the techniques of treatments are changing. You, for once, are one of the few people in this field who's attempting, newer ways of treating certain problems and moving slightly away from all those traditional methods or orthodox methods of treating knee problems. It is advertised as such that knee replacement should not be a problem. But so what are the problems associated with this traditional method of knee replacement?
Means knee replacement is a great surgery. Means it is considered one of the best surgeries of last century. It has given relief to millions of patients who were bedridden. Now they are pain-free walking. We should be thankful to our medical science that they devised such a procedure. But Shashank, there is nothing like a gold standard in life, which will always remain a gold standard.
Right.
Means there was a time when having a landline in the house was a gold standard.
Yeah.
Then came the mobile phone. Just having a mobile phone was like, it was considered the greatest invention. We were so happy. But again, we have to consider, means we have to think, if something is good, it can be made better. I understand something is good, can be best, but it can never be the best. There is always some drawback. There must be something that we can do about it.
Or just some room for improvement.
There is evolution in science. There is evolution in life. Nature has evolved from a single cell amoeba to a multi-organ human being. So similarly in science, and specifically in this AI era, it's not changing in years, it's changing in weeks and months. So something was a gold standard once upon a time.
Okay.
Then we should look into what the patient wants. Knee replacement removes everything that is natural in your knee. We talked about meniscus, we talked about ligaments.
Right.
We have to remove everything and place an artificial implant there. But if you are a young patient, you are 45, 50, you are having early arthritis, I cannot advise knee replacement to you because artificial implants have a shelf life. They cannot last forever. Let's wish that you live up to 90 years. But my implant will not last 40 years. It will not allow me to squat. It will not allow me to sit cross-legged. It will not allow me to do yoga. These are the basic requirements of an Indian lifestyle. All these implants were designed in Western countries where there is chair sitting. They don't sit on the floor. In our day-to-day life, we need to squat. We need to sit on the floor, either for social reasons, religious reasons, and so many times, even in daily activities.
Right.
So we have to look into those unsaid needs of the patient. Then we should have some alternative to these patients.
You spoke about early arthritis in certain patients. Can you quickly walk us through the journey of arthritis and the stages of arthritis?
For practical purposes, we have divided it into 4 stages.
Okay.
Stage of denial, stage of divergence, stage of desperation, and stage of dead end. I'll explain one by one.
Sure, yeah.
Initial stage, when you have occasional pain, stiffness, patient comes to us with a knee problem, that I have this issue, and we tell them that this is just the beginning of arthritis. You change your lifestyle, you reduce weight, strengthen your muscles, look out for your vitamin D and calcium levels. But patient is in a stage of denial. I'm healthy, I'm doing everything. I don't need medicines, I don't need regular physiotherapy or exercises. So that is one stage where we can actually reverse the process.
Oh, okay.
That stays for 5 years, 7 years,
That long.
that long.
And it across all this 5-7 year period, it's reversible.
It is reversible. It is reversible. Then comes the stage of divergence. Divergence means when you don't know where to go, what to do. And that is not patient's fault. This is the stage when you get your X-ray done and you find that the space between your bones is getting reduced, what we call a joint space.
Right.
The upper bone is femur, lower is tibia. The joint space starts reducing and the bones start just touching each other on the inner side of the knee, not on the outer side.
Okay.
Because our body is designed that more weight is borne through the inner side of the knee.
Acha.
So it's always 95% of the cases you start having pain on the inner side of the knee. When you get your X-ray done, the joint space is reduced on the inner side. So that is the stage when we tell one sentence to the patient. जब तक काम चलता है चलाइए.
I've heard that a lot.
Now this is a very vague statement and I call it a half sentence. The hidden part of the sentence is जब तक काम चलता है चलाइए, जब घुटना पूरी तरह खराब हो जाएगा तो we will replace it. Now this is a very paradoxical philosophy. Philosophy of medicine is stop the disease where it is. At least stop it if you can't reverse it. Don't allow the disease to go to a certain level where we need a surgery or where we need a radical procedure.
Right.
But in knee, because we have accepted that gold standard, that knee replacement will take care of everything.
Right. Right.
That has actually enslaved our thinking process that there is no other way except knee replacement. So please, जब तक काम चलता है चलाइए. Instead, it should be नहीं काम नहीं चलाना है, because that काम चलाना will take 10 years.
Right.
10 years of painful life where you will not be enjoying life, you will be taking painkillers, you will be gaining weight, your muscles are losing, you are having osteoporosis and you will have so many other problems. So काम नहीं चलाना है. We have to relieve the pain from day one and we will not allow your disease to go to a level where you need a knee replacement.
Yeah, I mean, uske baad people are left with no choice. I mean, there's no option. What, according to you, should not be ignored?
If you have frequent stiffness in your knee, if you have to take painkillers once or twice a week, frequent episodes of swelling, and you start losing your hobbies. For example, you are fond of running, you are doing some sports activity, and slowly you feel that you are getting away from your hobbies because of knee pain. You should not ignore it.
That's great advice.
Means these are subtle signs. No one will come and diagnose it for you.
Right.
It is your job to take the initiative.
And a lot of times also, I've seen people, or I'm sure all of us have seen people थोड़ा सा एक self diagnosis mode में आ जाते हैं. They try to diagnose कि okay, I'm feeling discomfort in my knees and this might be the problem or that might be the problem. Then can you shed some light on certain myths about the knee problems in general?
Actually, myths take origin when we don't have a place to go. Then these myths walk into your treatment cycle. I told you about stage of divergence. Because we give them this vague sentence, the patients start looking for options. You can get some injections in your knee. You can take some medicines which will regenerate your cartilage. And let me tell you, there are two tissues in body which can never be regenerated. One is nerve cell, second is cartilage. They can never be regenerated. And there are so many it's a whole industry. There are medicines like glucosamine and collagen and all those things which are supposed to regenerate your knee. The fact of the matter is that every medicine you take, after digestion, it goes into your bloodstream.
Right.
And you will be surprised to know that cartilage has no blood supply.
Oh.
So these medicines actually never reach the target area. So how can they regenerate?
And there's a huge segment of patients who are relying on these medications. There are other ways. There are procedures that can be administered at an early stage and avoid the total knee replacement altogether. And we've done a little bit of research ourselves. Yes. There is something that you do which is called the MRP, which is the Meniscus Replacement Procedure. What is the exact procedure? How is it different from the usual or traditional knee replacement? And when is it that a person can actually go for it to save the knee?
So again, we have to start from the pathology. The first culprit when we start having those knee stiffness and those symptoms is the loss of medial meniscus. If you look at the knee, as I've shown you,
Right. Medial is the inner part.
Inner part is medial, outer part is lateral. This is a right knee.
Right.
So there is a meniscus on this side that is called lateral meniscus.
Okay.
There is a soft cartilage, again medial meniscus. These are the two soft cushion-like structures. As we are designed to have more weight bearing on the medial side, so this medial meniscus, they start degenerating.
Oh.
There's a wear and tear in the meniscus. It's a soft structure. It's a very soft. Means like your ear. It's a cartilage. So it's the same texture.
Acha.
So your meniscus starts getting degenerated and getting displaced out of the joint. What we call meniscal extrusion. It is extruded from the joint. So these bones, they start touching each other. The problem is meniscal problems cannot be diagnosed with X-rays.
Oh.
And every time you go to a doctor with a knee problem, just X-rays are done. You never advised an MRI. MRI scans are never advised, especially if you are 45, 50 or 55. Because there is a foregone conclusion that ultimately you are going for a knee replacement. There is no fun. There is no use of doing an MRI. No, it's wrong. At an early stage, get an MRI scan done. You find that your meniscus, medial meniscus is getting degenerated. So we have to address the root cause, because meniscal problems is step one. What happens after the meniscal problem? Your legs start getting deformed. There is bow legs. You've seen people with bow legs. So once we start having bow legs, means our bones were like this, slowly they get starting separated from the outside. The inner joint space gets reduced and outer joint space gets widened. So this is the problem that is happening.
That's why the deformity happens.
So your knee is under biomechanical stress. And what was connecting these two bones were ligaments. You see, this is a ligament. This is another ligament. There are two ligaments in the center. They are called ACL and PCL. You might have heard about it. Anterior cruciate ligament and posterior cruciate ligament. ACL is in the center.
Okay.
So when your knee starts getting separated like this with bow legs, your ACL is stretched. And once that stretch is beyond 5 millimeter, your ACL gives way.
Oh.
So that is the second stage of arthritis.
Okay.
If we correct our bow legs before that 5 millimeter separation, we can revive our ACL.
Okay.
Because once the ACL is gone, the only choice left is knee replacement.
Acha. Okay.
If we step in before that 5 millimeter separation, we put something here which will tackle my bow legs, which will correct my bow legs, the ACL will come back.
It'll come back to its original.
Because this is a biological structure. It has blood supply. Once you remove the stress, it will revive. So how can we do it? We can simply replace the medial meniscus.
Okay.
So key is early diagnosis. Come before the ACL is damaged. We will correct your bow legs. We will put something which replaces your meniscus. I'll just show you the implant. This is a very small implant. Very small implant.
Oh, okay.
You put it between bones, femur and tibia. You push it between the bones, and that joint space which was reducing, it will come back to normal. Your bow legs will get corrected. Your ACL will revive. So that's why we tell our patient, come at stage 1, always stay young.
Are beautiful. So, sir, I'm sure because this is a new procedure, do you think there are certain myths about this meniscus replacement procedure?
Yes, whenever there's a new procedure, means it happens every time. There are certain questions, we call them speed breakers. You cannot straight away tell the patient that do this and they'll get it done. No, definitely they'll have questions, because we also promote inquiries. They should be inquisitive. They should find out. So the first question was that there's no procedure like MR, meniscus replacement procedure. Now I'll ask you a question. Do you understand anything with perceptive capacitive interface?
Not really.
You are using it at least 100 times every day.
Right.
This is touch screen. This is scientific name of a touch screen.
Touch screen. Okay.
But if some company tells you that we have very good perceptive capacitive interface, please buy it. You will not understand anything.
Right.
It's our job to make science simple and accessible. The technical name of MRP is meniscal bearing implant. You understand ball bearing?
Yep.
So this is meniscal bearing. Nature has given us a meniscus which is not fixed to either bone. If you look at the movements, it is a floating structure.
Oh.
Just like a ball bearing.
Right.
So the technical name is meniscal bearing implant. If I tell a patient, I'll give you meniscal bearing implant, they'll not understand anything. If I tell them that you have a meniscus which is not working, I'll replace it. So we simplified it for MRP. Catchy, easy to understand, and they can comprehend what I'm going to do.
Right.
That was objection number 1. Second objection was that MRP will last 5-6 years and then you have to go for a knee replacement. Now there is a difference of concept.
Okay.
I told you this is a floating structure, but There is a partial knee available in which this, you see this white thing
Yeah.
between two metals. This is called insert.
Okay.
It is fixed to the lower bone. You see, it's not moving.
Yeah.
It's not moving.
Right.
It's a fixed thing. So that means we are having a sliding friction here.
Correct.
Physics, sliding friction and rolling friction.
Right.
A car with wheels, a car without wheels. So if it is sliding friction, this will wear out within 5-6 years. But if I have a model which actually replicates the meniscal function, where the insert is not fixed, where the insert is floating. Now,
Just like the real meniscus.
yes. So I have converted a sliding friction into a rolling friction. Now my car has wheels.
Yeah.
The friction is less. It will last at least 15 to 20 years. This is one thing that I wanted to show.
Beautiful. Beautiful.
Third thing, if I put a plastic between two bones, not only it will damage the bones, it will get jammed after few years or few months. It will lose that sliding job. So I need to resurface my femur and tibia with small metal plates so that it can keep on sliding for next 20 years. So these are three things that people are slightly confused about. So thanks for asking this question.
Yeah, I mean, thanks for explaining it so nicely. I think this happens a lot of times when people come across a new procedure. They're either less informed or misinformed. So that creates sort of a block. So say we know that in a traditional knee transplant, you return to a certain level of mobility that you were.
Yes.
But say for a person like me or even younger people who somehow get this problem and they go for a meniscus replacement procedure, the question is how much of my original activity can I restore? Say for example, I love adventure sports. I go for trekking, I would love to go for skydiving or things that are actually, things that need mobility. Do you think I'd be able to go back to doing those things?
Absolutely. Our motto is don't survive, live life, enjoy it. Because I am giving you back your natural knee. Your knee is stable, complete range of movements. Means there is no threat to your implant because this implant is basically fitting in your natural knee.
Right.
We are not replacing your knee, keeping the knee natural so you can do all activities.
So even if I'm going for like strenuous treks or doing any other activities, my implants are safe.
Go ahead.
Wow. Beautiful. So yeah, I mean, I think that restores a lot of confidence in a person as well.
Yes.
And you also told us that this MRP, it's not a front incision.
Yes.
It is a side incision. So I think optically also it makes a lot of sense, right? I'm not looking at an ugly scar or a thing that keeps reminding me that I don't have my original knee with me or something. Do you think that plays a role in restoring someone's confidence?
If I talk about macro looks, means it will correct your bow legs. If you go slightly closer, it's a much smaller scar because there are no stitches and it's not in the front of the knee. It's on the side of the knee. So like if you are wearing short dresses or you are like in shorts or you are going outdoors, you never have to be conscious about it that you were ever operated.
Oh, that's amazing. So good to know. All our younger viewers, you have nothing to worry about. Good to know, sir. Thank you so much. So why do you think there is so much lack of awareness about these new methods?
Because these technologies are very rare to find. Rare to find means there are very few people who are doing these surgeries.
Oh, okay.
So we need actually to educate our younger surgeons. We need to include this in the curriculum that knee replacement should be a second option. First option should be knee preservation.
Right.
Joint preservation should be the priority. We should not aim for a replacement. Let's try to save the natural knee.
Yes.
We are not doing life-saving surgeries. We are not cardiac surgeons. So if we can delete those 10 years of painful life, this patient will be so happy. We are giving them 10, 15, maybe 20 years. This implant lasts 15 to 20 years. We are giving them a freedom, a luxury life for 20 years. And after that, there are two options. This surgery can be redone.
Oh.
One. Second, the knee replacement option is still there, but at that time you'll be 70 plus. So physical demands of a patient who is 50 years and who is 70 years are totally different.
So there are also a lot of younger patients, right? There is a natural process why this happens and how this happens, but there are some unnatural causes also, right? Some unfortunate accidents or maybe unforeseen situations where a person just ends up hurting their knee. How do you tackle such cases then?
In younger lot, we try to keep it as natural as possible. We try to maintain their leg lengths because they don't have an option of replacement. They don't have an option for meniscus replacement also because they are too young and they have the whole life ahead of them. And these are the people who would like to run, who would like to ride a bike, who would like to climb stairs two at a time. Means there are so many things left in their life. So we don't want to put any implant in these patients. But sometimes it is not possible, unfortunately. So many of these young patients go for replacement at early stage. Then it is our job to give them the best implants.
It depends on the kind of damage that they've
Type of damage there.
Yeah. So in a situation or in a field where there were so many misconceptions or rather limited information, I would call it, when people have just accepted that this is all there is, how did you start something like this, and what were the challenges that you faced while introducing this to your patients and people outside?
Because knee replacement has been in vogue for many, many years.
Yeah.
And there are great results also. I'm no denying in that. But when 10 doctors are saying that you need a knee replacement, suddenly 11th doctor says, no, we can save your knee, we can preserve your knee, you can do all. This looks unbelievable. So that
you can't be pushy also, right, with the patient.
We cannot,
because they'll start feeling maybe they're trying to convince us of something that is against the popular opinion.
There was a statement there's a quote by Victor Hugo. He said, no military can stop a great idea whose time has come.
Beautiful line, beautiful line. So now that you have introduced this new procedure to so many people, I believe you've already completed over 2,000 successful MRPs.
Yes.
What are the kind of benefits that people are experiencing after getting through these kind of surgeries as opposed to the traditional knee replacement?
It's a much smaller surgery. It's just hardly 3 inches of incision. And traditional surgery in knee replacement, you get bigger incision in the middle of the front of the knee. It is on the side of the knee, smaller incision. The recovery time is so smaller, means almost half. It takes 3 to 4 weeks for a person to get back to normal. They can drive, they can go to office. And it's not just the recovery time, it's actually the number of painkillers and antibiotics that you end up taking when you go for a massive surgery like knee replacement.
Correct.
We are reducing the number of analgesics, means painkillers, antibiotics, and that when you are in pain, your body secretes negative chemicals. I'm not going into details of that. It affects your overall health and well-being. It affects your appetite. It affects your mood. It affects your psyche.
Correct.
So the idea of a minimal invasive surgery like MRP is minimal collateral damage. Touch only that part of the organ which actually needs to be invaded.
Any other key differences that you would like to highlight, whether it can be technical or it can be, in the later stages while recovery or after recovery?
There is a sensation. We talk about touch, pain, smell, all those things. But there is a different sensation, what we call proprioception.
Okay.
Proprioception is like I'm closing my eyes. I know my fist is closed. I know it is open. How do I know it? Because every joint has sensors. They are called mechanoreceptors.
Okay.
Which will tell me how my limb is positioned even without looking at it. Proprioception, what we call in an athlete, why do they train? Because they are training their mechanoreceptors. The ligaments in every joint, like ACL ligament in your knee, it has mechanoreceptors. If my knee is rotating or I'm placing it somewhere, my brain knows where it is located. So once I lose those ligaments in a surgery like knee replacement, I lose proprioception. I don't know in which direction I'm moving. I'm unsure. I'm unsteady. Means if I'm walking in a crowd, someone pushes me, I'll feel unstable because not only the stability is gone, but I don't know where my knee is. So proprioception is one sensation which is understated. We don't talk about it.
Yeah, I mean, this is the first I'm hearing about it. Yes. And I think all our viewers would be really happy to know these implications as well. I mean, it's practically letting the patient feel they're still whole. Now you've been associated with the hospital, and you mentioned that when a patient walks in, it's not just the patient, but anything that is going to happen to the patient is going to implicate the entire family. So many lives are affected, so many people are affected, their futures depend on it. How does CK Birla comes into the picture? How does it ensures that they are taking care of not just the patient but also the families?
Actually, family is very crucial for me as a surgeon. If I look at a practical point, my patient is with me just for a few minutes every day when I go for rounds. The rest of the 24 hours, the family is with the patient. If family is properly counseled, they are informed, and they are at peace, they will support my patient. They will help the patient recovering from it. If the family is disturbed, they don't know what's going on, they're also confused, that adds to the agony of the patient.
Right.
I need that support system. So my hospital is very particular about it. Before the surgery, we take sessions explaining everything like we are explaining here. Every family is explained about this, about the financial implications, about the possible complications. If there is a complication, how we are going to handle it. We are fully equipped about it so that they are assured that they are at the right place. So this is one thing, means we don't treat just the patient. We take that whole group of people and we walk them through the journey, possible roadblocks that can happen, and how we will take care of it. So we need all of them to be very calm and composed that yes, we are in the right hands.
So we'll just try and dig a little deeper into that person, not Dr. Ashwani Maichand, but just Ashwani. Who is he as a person? So I'll just quickly ask you a few questions, and I'm sure our viewers would like to know who is this person behind the robe and behind the doctor's coat. So we know you love coffee. So when do you like to take your coffee, like before the rounds or after the rounds?
After the rounds, where we can relax with each other, we can talk about it, we can share our problems also, and we can appreciate someone's good job.
Very nice, very nice. What is that one thing that people would be surprised to know about you?
I love tennis.
Acha, what is the funniest question a patient must have asked you ever? Like, funniest question.
You heard about AVN? There's a disease called avascular necrosis of the hip.
No, I haven't heard of it.
There is a lack of blood supply in the hip, and that causes the patient to undergo hip replacement ultimately.
Okay.
One of the causes is alcohol.
Alcohol?
Yeah.
Okay.
Alcohol can cause AVN.
Okay.
Now, I treated one of my patients, I replaced both his hips, everything was fine, and after 3 months, he asked me, how much can I take?
Okay, so if you were not a doctor, what would you have been? Like, what profession would you have chosen?
Cricketer.
Cricketer?
I was a good cricket player in my school, college days.
And are you a morning person or are you a night owl?
I stress the night till it's morning.
So the lines are blurred to you. Good to know. Okay, one book or a movie that you would recommend your viewers?
This movie actually, this applies to everyone's life.
Okay.
About perseverance. Shawshank Redemption.
Yeah.
That is one movie that tells you if you do a scratch every day,
yeah,
at the end of it, you'll reach your goal.
It's such a classic and such a beautiful example to quote.
Yeah.
Sir, next set of questions, बहुत quickly करेंगे, like a rapid fire. One word answer, first thing that comes to your mind.
Okay.
What's your favorite healthy snack?
Omelette.
What's your favorite exercise?
Running.
Most underrated health habit?
Yoga.
Sleep or workout, which is more important?
Sleep.
One word that defines CK Birla Hospital?
Premium.
One piece of advice for your young doctors?
Innovate.
And one message you'd like every viewer to remember after watching this podcast?
स्वस्थ रहो, समर्थ रहो, स्पष्ट रहो.
Beautiful, beautiful. I think I couldn't have put it any better than that. This was such an amazing conversation. So much so that I just don't feel like letting this go. I just want to keep talking more and more. But I know you have a lot of patients to cater to. All those people that we just spoke about, they might be waiting for you. So just before wrapping this up, very, very quickly, if you have to summarize the whole thing, how would you put it in a nutshell?
Your health is your responsibility. Be alert and be aware. What you are suffering from, what is your diagnosis? What are the treatment options available? You should research before going into any treatment. I'm not saying you don't trust your doctor. Trust science. We are all depending on science. It's like a religion now. But again, research. Look at the options. Means now you have everything at your hand. Means you have Google, ChatGPT, AI, everything is available. You cannot blame that I didn't know it. So please have a complete research. Ask as many professionals as possible before going into for a surgical procedure or anything. You will always get the best.
Thank you so much, Dr. Maichand. I think this was very informative, very entertaining, and it also helped us take a little peek in your life, in you as a person. Thank you so much for doing this with us. It was a pleasure having you. So that was Dr. Ashwani Maichand. I hope you enjoyed our little conversation. Thank you for tuning in. Don't forget to follow and subscribe for more such content, and we'll be back with another guest, another topic. Till then, thank you and goodbye.